afternoon, everyone. I am sorry I'm unable to join you in person. I would like to thank the organizers and especially Dr. Avinash and Manoj for inviting me to give this talk. Over the next few minutes, I will be talking about post-ERCP pancreatitis and where we are today in management of this dreaded complication. So post-ERCP pancreatitis, we know, can be categorized as patient-related risk factors where we've had further insights, procedural-related risk factors, which over time are better defined. Pancreatic stents are, I think, here to stay, at least for a while. Pharmacology, we've had some established worth, and we will review the data. And I've intentionally spelled the fluids different so that you can remember the acronym, and there is emerging efficacy of use of fluids to minimize the risk of pancreatitis. So based on multiple studies and multivariate analysis, the risk factors, if you know, for patient-related are female, younger age, suspected sphincter 4D dysfunction, and prior history of post-ERCP pancreatitis. If somebody has chronic pancreatitis, they're smokers or they have liver disease, this somehow seems to be somewhat protective. We also know from procedure risk factors, pancreatic injections, especially the extent of injection, pancreatic wire placement, if you have had difficult or failed cannulation, precut sphincterotomies, metallic or large biliary stent placements in the absence of a sphincterotomy, balloon sphincteroplasty, again without a sphincterotomy, pancreatic sphincterotomy, minor papillotomy, and ampulectomy. These are all procedure-related risk factors. So the risk factors for post-ERCP pancreatitis, as anybody who does these procedures agrees, are very cumulative. They're not 1 + 1 is 2, but they keep adding up very quickly. So if you take a female, especially with normal bilirubin, you see more than jumps to double. But you add to that suspected sphincter 4D dysfunction, the risk significantly compounds and increases. So your highest risk factor would be a female with a normal bilirubin who've had difficult cannulation in a suspected sphincter 4D dysfunction. So your patient risk, based on this, your patient selection indication for doing the procedure becomes very important. Recently, we have these short wire systems that have been introduced. And the reason is that when you have a technician manipulating the guide wire and advancing it into the bile duct or the pancreatic duct, there is no feedback of a tactile mechanism. And the idea is that if you feel it, you would be better. So as an endoscopist, if you have a feel for it, you might actually control the wire better. And this clearly shows that when you have endoscopists controlling the guide wire, the risk of post-ERCP pancreatitis is much lower. So here is a nice picture that shows the wire in the bile duct, the wire in the pancreatic duct. And here, if you look at it, it looks like the wire is going into the bile duct, right? It's going up towards the scope, and here you see the clips from post-cholecystectomy. When you inject contrast, you can actually see that this is the bile duct filled with stones. Your guide wire is not in the bile duct, and this is the answer loop of the pancreas. So the guide wire here has perforated through the side branch of the pancreas and going up. So you have to be extremely careful where this is going. So in my practice, I usually inject a little bit to see where the direction is and where the guide wire is going. So please don't blindly advance the guide wires, and you actually increase the risk of pancreatitis. Again, we all know from the old studies that all of these are risk factors. What I would like to draw your attention is that even a single passage of a guide wire into the pancreatic duct, deep into the pancreatic duct, increases your risk of pancreatitis. And the odds ratio, when you adjust, it's as high as doing a needle-knife sphincterotomy. So you have to be careful. So this again is a study that was published in GI endoscopy that shows that Compared to PD opacification, we were all taught that you should not be opacifying the pancreatic duct because we are worried about potential acidorization and pancreatitis. But as opposed to that, if you have actually now a guide wire insertion, the risk is significantly higher. So please be careful for those who are solely relying on guide wire passage. And a guide wire, just saying only a guide wire pass once is not sufficient. And these are all the various risk factors. And if you look at it, the guide wire passage has an odds ratio of 2.77, almost as high as pancreatic sphincterotomy here. So one has to be careful. This is a very nice guideline that is published by the ESG in endoscopy. How about pancreatic stents? So the idea of putting a pancreatic stent is that you minimize the risk of the periampullary edema. You allow the drainage of pancreatic secretions, thereby you minimize the risk. And the indications that we know where it works are after biliary and endoscopic sphincterotomy based on Paul Ternaski's study, there is a significant risk reduction. So also after a difficult cannulation, and after a pre-cut papillotomy. This is a retrospective study looking at pancreatitis after ampulectomy, and there has been a significant risk, about from 33% in those who did not have stent to almost 0% in those who've had stents after an ampulectomy. So the procedure-related risk factors are established well, and I think placement of a pancreatic duct stent here definitely would minimize your risk of pancreatitis. And here you can see in this picture how nicely the pancreatic secretions are drained and minimizing the risk. So how about PD stent after a guide wire passage? And here you can see that there is a guide wire in the pancreatic duct, guide wire in the bile duct. And when the guide wire goes deep inside placement of a stent, if you do not place a stent, the risk of post-ERCP pancreatitis is about 23%, drops to less than 3% when you have a stent placed. So when you get a guide wire into the PD, especially with a difficult ampullary anatomy or papilla, there is nothing wrong with it. Leave the wire and cannulate alongside into the bile duct, but make sure you actually place a stent in the PD so that you minimize the risk of pancreatitis. So use the pancreatic duct, but do not misuse it. Pancreatic stent after all ERCPs, again, it shows that there is a significant risk, but that does not mean that we should be trying to go and spend an extra 20 minutes cannulating, trying to cause more trauma to the papilla. So you have to be careful. These are some of the meta-analysis that actually show that stenting favors reduction in post-ERCP pancreatitis. Again, this is another meta-analysis that is done that that favors stenting in reduction of post-ERCP pancreatitis. So pancreatic stenting does reduce pancreatitis. So is it effective in all cases? But I think it is effective, but instead of causing more trauma and damage, I think it is effective in high-risk cases. Which stent would we choose? What is optimal? We do not know whether it's a long stent, short stent, whether a no flange stent, single flange stent. What I do believe is that we should not oversize the stent. So you should not be using large stents, 5 French stents, 7 French stents, or 10 French stents in a small, normal-looking duct. So try to use a 3 to 4 French stent. And if you use a 5 French stent, a short stent without an internal flange probably is optimal. Though there are data that suggest that even a short-term placement of a stent can cause pancreatic duct stricture. So be careful when you choose the stent. Stenting the difficult pancreatic duct is hard, especially if you have an ANSA loop in the head of the pancreas. So you need to be able to place small guide wires and place small stents. There is a significant risk of trying and failing. So if you cannot readily get into the PD, I don't think you should be trying to traumatize the papilla and try to get a stent, because when you try and fail, the risk of pancreatitis is greater than 50% or more. And should pancreatic duct stents be the standard of practice? I think for all of us who do ERCPs, you should be comfortable with the idea of placing a wire in the pancreatic duct and placement of a stent, because you never know which case turns out difficult and where you need to stent. Last but not the least, as we are all doing, using NSAIDs, are NSAIDs just adequate or to replace the PD stents? So the story of NSAIDs is the most recent story in reduction of post-ERCP pancreatitis. This is the landmark paper that was published in New England Journal almost a decade ago. I think it shows that this is the placebo group, this is the rectal indomethacin group. There is a significant reduction in pancreatitis after administration of rectal indomethacin. Again, it's just not reduction in the incidence of pancreatitis, but also the severity of pancreatitis is minimized. The adverse events is not statistically significant, though there is some bleeding. The bleeding risk is similar compared to placebo and indomethacin, and no concern for renal failure. So rectal indomethacin can be administered. However, should we go ahead and start giving rectal indomethacin in every patient that you do ERCP? This is a study that looked at administration of rectal indomethacin in consecutive patients, and here it does not show any reduction in pancreatitis. So for high-risk patients, yes, there seems to be a benefit. Again, this is a study that was looking at NSAID use for prevention of post-ERCP pancreatitis. It's an updated meta-analysis of controlled trials, and it shows a single dose of rectal NSAIDs is effective in preventing post-ERCP pancreatitis, both in high-risk and unselected patients, regardless of the timing, whether you give it before or during the procedure or after the procedure, or whichever is available, either rectal diclofenac or indomethacin. So this is another meta-analysis that was published recently that looked at prophylactic rectal indomethacin in post-ERCP pancreatitis in general patients. It seems to be ineffective, but seems to be useful in high-risk patients. So recently, we published a study as part of this group with the Indiana, looking at, we know that there is a benefit in giving 100 milligrams of rectal indomethacin, and we are all, as human beings, we always are saying, well, if something works, twice as much should be even better, right? So we thought, why don't we do a dose escalation? So we did a rectal indomethacin dose escalation for prevention of post-ERCP pancreatitis, or the RIDE trial. And we randomized patients to either 200 milligrams or 100 milligrams, which is a standard dose. And there is no advantage of giving a higher dose. And the risk of post-ERCP pancreatitis is still high in the high-risk group. So just giving rectal indomethacin and hoping that nothing will happen is not a good strategy. So routine pre-procedural rectal indomethacin to prevent ERCP. Again, it's a single-blinded randomized controlled trial. It shows that it does favor routine administration. So we have somewhat conflicting data whether we should give it to all ERCPs or just high risk. And I think at this time, we should probably just limit it to administration of rectal indomethacin in any person that you feel is a high risk. So you might start off with a low risk patient pre-procedure, but whatever procedurally, whatever you're doing might put the patient at higher risk. So you can still administer rectal indomethacin during or after the procedure. And I think standard dose, which is 100 milligrams of rectal indomethacin, is efficacious. There is no role for administration of a higher dose. And if you can, you're better off giving it before the procedure. So again, I want you to remember that if those of the patients who are still getting NSAIDs just as a sole prophylaxis have a 6 to 15% risk, based on the data that are available. And are they about to replace the PD stents completely? Should we be getting rid of all the pancreatic duct stents? The answer is probably not yet. So Venkat Akshintala from India actually looked at a network meta-analysis, and he thought that use of topical epinephrine and rectal NSAIDs are most efficacious agents in prevention of post-ERCP pancreatitis. Subsequently, the Johns Hopkins group has collaborated with several of the practices in India, and some of you have participated in these studies, and they've done a large study that looked at topical epinephrine spray along with rectal indomethacin, and actually it did not reduce the incidence of post-ERCP pancreatitis compared to rectal indomethacin alone in high-risk patients. So the story of rectal indomethacin is that it probably does not work, and maybe, in fact, it actually increases your risk of pancreatitis. So pharmacological prophylaxis alone probably is not adequate to prevent post-ERCP pancreatitis. How about fluids? I started off with a small pilot study that looked at 8 hours of fluid administration post-procedure, standard fluids in 23 patients. And it showed that the post-ERCP pancreatitis, when you actually give more fluids, is almost zero compared to 17% in the standard group. So multiple studies were performed, again, in this double-blind randomized controlled study, where if you give 3 ml per kilogram per hour for 8 hours versus with a 10 ml bolus, compared to 1.5 milliliters per kilogram, the aggressive IV hydration group had a significantly lower risk of post-ERCP pancreatitis. Again, this is a meta-analysis that looked at it, that aggressive hydration reduces the overall incidence of post-ERCP pancreatitis. So most studies showed benefit in post-procedure hydration, at least for 8 hours. It is probably not feasible for majority of practice. You do the procedure, you send the patient home in an hour or two. So keeping the patient for about 8 hours and administering the fluids might or might not be feasible. In our practice, we do give fluids widely open prior to the procedure, during the procedure, and immediately after, so that at least you hydrate the patient well enough. But again, studies have shown that benefit is there if you actually administer it for 8 hours. So what we do not know is the efficacy of brief hydration, and probably in time we would have data for this. So in summary, we all know that post-ERCP pancreatitis can be divided into patient-related risk factors, procedure-related risk factors, use of pancreatic stents, pharmacology, and use of fluids. So you have to be very careful in which patients you're selecting to do the procedure, and you should do them only when it is indicated, and only indicated patients should get the procedures done. Procedural risk factors should be evaluated and, if possible, intervened appropriately, either by placement of stents, use of drugs, or hydration. And pancreatic stents, when used, have to be done carefully, choosing the right size stent for a brief period. And pharmacology, right now we have data that administration of NSAIDs in high-risk groups is efficacious, not in all comers, and just a standard dose alone seems to be enough. We do have data that 8-hour administration of fluids, especially lactated ringers, is beneficial. We do not know the efficacy of short-term aggressive hydration. And I think instead of just choosing one, two, or others, I think a combined approach is probably beneficial based on your patient needs and the procedure needs. So do not dogmatically adhere to a single approach. Thank you for your attention.
Good evening, one and all. I am Dr. Avinash. I am an associate professor in the Department of Gastroenterology at MS Ramaya Medical College and Hospitals, Bengaluru. So it is indeed my pleasure to present to you this lecture on post-ERCP bleeding. The next 20 minutes of my talk, so we are going to deal with what is the definition of post-ERCP bleeding. So what are the risk factors, that is patient-wise and procedure-wise, and how are we going to manage the post-ERCP bleeding? So the definition is like any upper GI bleed, it is similar hematemesis and or melena. But most important thing that they have mentioned is hemoglobin drop of more than 2 grams per deciliter. It can be immediate, that is during the time of procedure. Majority of them will be self-limited, or it can be delayed, so which can be hours after the ERCP, or it can extend up to 10 days post-procedure. The 2007 meta-analysis by Todd Barron et al. So has mentioned an overall bleeding rate of 1.3%, of which 71% were moderate and 29% were severe, with an overall mortality rate of 0.05%. So majority of my slides are from ESG guidelines that got published in Endoscopy 2020. So like the incidence and the mortality rates were similar. So, but the thing is like they have defined what is the severity. When we say mild, so it is either of the following, that is abortion, like that is stopping of the procedure, like bleeding, which necessitates stopping of the procedure, or which causes an unplanned admission for less than 4 nights. And in severe, there is an unplanned admission which is more than 10 nights, needing an ICU admission for a night, requiring surgery and a permanent disability. Moderate will be somewhere in between, that is 4 to 10 nights with an ICU admission. But whenever we say a repeat endoscopy is needed for a rebleed, or an intervention radiology procedure is needed, or there is some intervention that is needed for integument injuries, that is something has happened and we need to do something, so that will be like considered as moderate in the severity. So we come to the risk factors, that is the patient risk factors. So before we take up the procedure, we always divide it into pre-procedure, intra-procedure, and a post-procedure. The pre-procedure are the patient risk factors. We categorize the patient as a low risk or a high risk. Low risk patients are all who are having ischemic heart disease without coronary, that is obstructive coronary artery disease. People who tend to have either cerebrovascular or a peripheral vascular disease. Atrial fibrillation without concomitant valvular disease. A prosthetic metal aortic valve. So these are all comprised of low risk patient risk factors for a post ERCP bleed. When we say high risk, that is an obstructive coronary artery disease with stent, prosthetic metal mitral valve, and atrial fibrillation with mitral stenosis. These are all the patients who are having high risk, or whom we consider as high risk patients. Coming to the drug, majority of these patients are cardiac or a neurology patients. We should have a consultation liaison with the cardiologist or a neurologist, because when to stop the drug, like because risk stratification from their side also we need to take it into consideration. And when do we restart the drug, same drug after the procedure? Majority of the time, aspirin single drug we are going to continue during the procedure, unless or until it is a case of ampulectomy where we may have to consider stopping aspirin for at least a 5 days time. Clopidogrel, definitely it has to be stopped 5 days, but again, it depends upon whether we can continue it based on the procedure risk. Warfarin, we may have to stop. We may have to wait till INR is less than 1.5. So after 2 days after stopping warfarin, we may have to overlap with low molecular weight heparin. Nowadays, more and more patients are on directly acting oral anticoagulants. So we may have to stop them for more than 48 hours. And if at all a person has got renal failure, which will decrease the drug clearance, we may have to stop them for 72 hours. To summarize the risk factors, so one is the anticoagulant intake. A patient who has a platelet count which is less than 50,000, it can happen in cholangitis indications. At that time, we may think about decompressing the drug, not decompressing the duct, rather than doing a definitive procedure. Patient who tend to have a bleeding diathesis, either in the form of cirrhosis, or a patient who is having end-stage renal disease requiring dialysis. During the procedure, whenever we tend to have intra-procedural bleeding, and there is a low volume of the endoscopist, like we do once in a while ERCP, there can be higher chance of post-ERCP bleeding. Coming to the intra-procedure, that is during the procedure, we again categorize the risk factors into low risk or a high risk. Low risk are the ones where we stent the bile duct without doing a sphincterotomy, or we just do a cholangioscopy. So these two comprise of low risk procedures. High risk procedure is whenever we tend to combine ERCP with sphincterotomy or sphincteroplasty, or we tend to do an ampulectomy for an ampullary adenoma. So like these are all high risk procedures. Intra-procedure, the most important thing that we tend to have, do is a biliary sphincterotomy. So where we tend to, like, this is a like a large stone at the ampulla, and once we cut, there is a pus that is flowing, so predominantly cholangitis. Or we tend to do, whenever we are doing a pre-cut sphincterotomy, at that time also it can bleed from the apex of the cut. So the most common high-risk scenario is for the biliary sphincterotomy. So it should be avoided whenever we think about doing only a biliary stenting. If at all we do a day's procedure, that is dilatation-assisted stone extraction, so at that time also we need to keep a concern on what is happening at the apex of the sphincterotomy. So how much is the length of the cut, that we should always remember. Like, the safety of the cut should be like just up to the level of the duodenal fold above the sphincter. Concomitant chronic liver disease, endoscopic experience, that is less than 200 procedures per year. Association of pancreatic sphincterotomy, so we might be doing cut twice, as well as whenever the center volume is more than 200 procedures per year. So because the bleed rate is per 100, so whenever the procedure numbers increase, definitely we tend to see a couple of cases which tend to bleed. That should not cause much of a problem. So coming to the little tips on the endoscopic sphincterotomy, so that is, in the incision, it's always better to have an endocut, so which tend to have a blended between cut and coagulation. It's always better to have a standard wire, that is a wire within the bile duct, and nowadays we tend to use more of Olympus Vio D3, so we need to keep the effector 2 and a forced coag of 40 to 60 watts. The length of the cut is usually 5 to 10 millimeters. Generally, we tend to cut up to a 5 millimeter to 1 centimeter, depending upon the papillary morphology as well as the bile duct diameter distally and the stone diameter. So 3 things, like what is happening at the papilla, so proximal to that, what is happening in the distal bile duct, and what is the endotherapy that we are trying to do. So papilla should always be incised at 10 or 11 o'clock position. So like at the time, there is only 10% of all the papillary arteries are there, so the bleed chances are much lesser. So whenever the cut direction is in that area, so either it is a combination of the sphincterotome bowing, the right torque on the scope, as well as on the big wheel on the scope. It's always important that we finish the cut, even though there is a little bit of bleed. So whenever we cut, bleed is going to happen. It's always better that we finish off the cut. Otherwise, like if it is only part of the cut, so once we finish the cut, the vessel gets cut through and through. At that time, the vessel recoiling will happen. The bleed control rate will be much better. It's always better to avoid zipper cut, that is excessive bowing on the sphincterotome, as well as intermittent cutting or incomplete cutting. Sometimes we tend to use the pre-cut sphincterotomy top down as well as bottom up. Then we tend to lose the anatomy, and we don't know where the biliary or the pancreatic orifice is going to come. So the trick in pre-cut sphincterotomy is never lose on the anatomy. Even though we cut 2 times, pre-cut 2 times, like it's always better to keep the anatomy in place, such that 48 hours later, whenever we go in, definitely it would have much opened up, identify the biliary orifice and the pancreatic orifice much better. Water jet comes in very handy. So whenever we tend to have a high volume water jet, it can visualize it much better. So whenever we tend to have a low volume water jet, so the bleed which is happening, we tend to, the vision will get obscured. So always have a high flow water jet. So it will give you the optimal visualization of the bleeder, and it will help us to do the proper endotherapy. And like which stent are we going to place? This is like whether it is a plastic or metallic. So that will be discussed in the next subsequent slides. The management of post-ERCP bleed and peptic ulcer bleed is very similar. So because we tend to use the adrenaline injection, heater probe, clip, hemospray, and rescue is always an angio or the surgery. But 2 things which are different in the post-ERC bleed are usage of a 9-12 millimeter balloon, that is our stone extraction balloon, which can be used as a tamponade. Like we can insufflate at the apex of the keeping the balloon in the bile duct, and then we can insufflate such that it can tamponade effect, or else we can place a fully covered metallic stent. So apart from this, the management of post-ERC bleed and peptic ulcer bleed are similar. So coming to the injection, so similar to that, like peptic ulcer, like 1:10,000 diluted adrenaline we tend to inject predominantly at the apex of the cut. So like we see that this is a cut that has happened, it is oozing from there. So we try to inject that. In peptic ulcer bleed, we do a 4-quadrant. Here we tend to do only on a semicircular fashion at the apex, such that the underlying submucosal vessel can be separated from the mucosal breach that has happened. So we don't inject on the bottom area because that's where the pancreatic orifice is going to open, and at that time there can be a chance that post-procedurally pancreatitis may happen. In prospective study of 79 patients, like 100% success and minor bleeding rate is only 14%. So this is a study again by Todd Barron et al., where after the injection, you can see this blanching that should happen. That means we have injected in the proper plane. Suppose we tend to have a clot similar to the adherent clot, we try to gulleton it with the snare and then try to identify the bleeder to do the definitive endotherapy using a mechanical or a thermal. Thermal, we tend to use heater probe. So we can see that the bleeding spot is here. So we try to put a heater probe and then we cauterize it so that the bleed rate can come down. So this is a proposed algorithm for treatment of immediate post sphincterotomy bleeding. So this is whenever immediately following a sphincterotomy, still intra-procedural. So if at all the visibility is good, so that we continue on the procedure. If at all the visibility is not good, we wash with water. And then if the visibility is good, we continue the procedure and we do the definitive therapy. If the visibility is improper and we find that the bleed is significant, then we inject. And if the bleed is controlled, we continue the procedure. If the bleed is not controlled, so then we tend to add on to another endotherapy similar to the dual modality of treatment, where we try to put a clip or a heater probe. And then we try to abort the procedure, and 48 hours later, we can redo the procedure. Or if the person continues to bleed or something, we may have to go for angiography or embolization or surgery. So peptic ulcer bleed generally has got a big role for proton pump inhibitors, but a large observational studies has shown that either use pre-dose with esomeprazole or continue esomeprazole, it doesn't reduce the risk of either intraprocedural or delayed bleeding. Dual modality of therapy is much better in this retrospective study, so where they have combined epinephrine along with thermal therapy, and you see that the initial hemostasis reaches 100% with a rebleed rate of only 12%, whereas with just adrenaline alone, it is only 96% and a rebleed rate which is little higher than the combination therapy. So it is always better to have a dual therapy. So like this is one of our case where a couple of old stents were there. Once we remove it, so there is a bleed. There's a patient who had malignancy, and after that we have exchanged the stent, and that became the tamponade effect and became better. So we placed clips like in patients who tend to have a significant rebleed. So the most important precautions that we always take is like we should not do any mechanical or thermal therapy at the bottom. So the dictum always says pancreatic duct comes at the bottom, that is at the floor of the papilla, whereas the bile duct goes to the roof of the papilla. So whenever we try to cannulate, we go to the roof, that is bile duct, and the mechanical or thermal therapy should never be applied at the close vicinity at the bottom, because removed, otherwise they cause ductal obstruction and then subsequent cholangitis or pancreatitis. How are you going to prevent? So either by placing, but most important recommendation that ESG tells is it's always better to have a nasobiliary drain in place, because we keep flushing the duct and chance of cholangitis happening again will not be there. Intervention radiology and surgery, these two people are our main people whom we go for rebleed scenario. But in endoscopy suit, we can always place a fully covered metallic stent, which can be removed in 4 to 8 weeks time, because it will significantly reduce the bleeding rate, because the diameter is almost like a 1 centimeter, and as well as there is lesser chance of blood transfusion requirement. Couple of other modalities which have come recently is a hemostatic powder. So like these are all rescue therapies. ESG doesn't recommend that, but rebleed rates are much better whenever we tend to use the hemospray. So this is from Wilson Cook. This achieves hemostasis by concentrating the clotting factors by forming a mechanical plug on the vessel. So such that whenever the powder is sprayed at the bleeding spot, especially when the vision is not so clear, so then we try to use this with the delivery catheter, which is connected to a carbon dioxide canister, and the powder will spill and the hemostasis can be achieved. So it will give a temporary benefit. So definitely like 48 hours, the amount of bleed will definitely come down, but it has not yet come into the recommendation. Embolization of refractory post sphincterotomy bleed is definitely yes. So here we take the help of intervention radiologists who try to do the arteriogram and then try to identify the where exactly is the leak. And once we identify, then we try to coil embolize that area, and you can see that in the subsequent slide there is no bleed. So the endoscopically placed metal clips, which are stainless steel, that will give an indirect marker like what will be the culprit vessel or where is the culprit vessel that has to be coiled. So that will give the roadmap for the radiologist. So that was taken from the article. So risk factors for delayed and severe post-sphincterotomy bleed in a retrospective study of 161 patients is predominantly whenever a person who had an initial moderate bleed or a person is jaundiced. So these two are very important risk factors for severe bleed. So this is a proposed algorithm for treatment of delayed post-sphincterotomy bleed. So like the first important thing is the ABC, airway bleeding and circulation, like where we need to resuscitate the patient. So once the patient is stabilized, then we take up to the endoscopy suite. Endoscopy reveals a clean ulcer at the cut site, no need for any endotherapy. If a person has got an adherent clot, so then aggressive irrigation with a high jet water pump, or we can gulleton the clot using a snare forceps after we inject the adrenaline in a semicircular fashion. So once we remove the clot, then we find that the stigmata or we find the bleeding vessel, then we do the double therapy, which is a mechanical using a clip or a heater probe. So suppose whenever it is continues to bleed, then the rescue will be angiography, embolization or surgery. So the take home message is always extend the cut, complete the cut. So don't do a half cut. So then the vessel recoiling will be a problem. Either we spray or inject adrenaline, predominantly diluted 1:10,000. So we can use the 912 stone extraction balloon at the distal end of the bile duct as a tamponade effect, such that the bleed can be controlled. So we use a high water jet such that the visibility is not a problem. We do thermal devices to control the bleed, and rescue is always an intervention radiologist or a surgery. After we place a nasobiliary drain or a fully covered metal stent in case of rebleed or a refractory post-sphincterotomy bleed. So whether there is any role of endoscopic ultrasound to see the bleed, the culprit vessel, what is the diameter of the culprit vessel, or the rebleed rate is much more, where we can do a fine needle injection of either a coil or a glue, because nowadays we are coming up more and more on vascular endotherapy by endoscopic ultrasound is still a research question. So that concludes my talk, and thank you for patience listening. Thank you, one and all.
It was a very nice lecture. I think in our clinical practice, we should always look for the immediate bleeding, and that will suggest that post-sphincterotomy bleeding will later on occur or not. So in our clinical practice, we do sphincterotomy, and then if the patient bleeds, we extend the cut, we do the saline adrenaline injection, and if it continues to bleed, we do the heater probe therapy or gold probe therapy. And even if it still started bleeding and then it does not get controlled, we immediately go for the covered metal stent. It is now our routine practice that we use covered metal stent more and more, and it almost always helps, except one patient where it again bleeds and patient has to go for this embolization therapy. So I think it is better to predict the delayed. You can predict the delayed bleeding also while the first therapy only, because if patient has severe bleeding at the first time, it has more chances of bleeding later on also. So you have to be very careful. We are using more and more fibrin glue also. Like we use Endocril as as good as fibrin glue for bleeding post sphincterotomy, and we have used Endon gastroscope with cap to place clips because most of the bleedings are at the sphincterotomy site. So we can use the Endon endoscope with normal Olympus or any other clips to control this bleeding. Umesh, what is your opinion?
Yeah, thank you, Sanjay. I think Avinash has covered it, most of it, and you have added few points. Very relevant, I think, in the post ERCP bleeding setting. Most of the times in the ERCP, post ERCP bleed, they'll stop by the time you finish the procedure. And whether it is a pre-cut related, most of the times it's a pre-cut related bleeds are not heavy bleeds and they're mild loose and they stop while you are trying to cannulate. And the sphincterotomy bleeds, it will bleed at the apex, and by the time, most of the times you finish the procedure, it will stop. But in certain cases, if it is a little excessive, you can use adrenaline or balloon tamponade in the common scenario. As you said, I think most of the times we use this thermal methods. You can use the coagulation part of it. When you use the cutting current, suppose there is a bleed, you can use a coagulation current and stop it. Most of the times that will help. As you said, off late, I think in many centers, putting a SEMS, self-expanding metal stent, will be sufficient, and that will prevent patient going for IR or surgery. Most of the times that will be sufficient. One other point I want to add is, especially in the setting of EHPVO, extrahepatic portal vein obstruction, if there is a bleed or if you anticipate bleed, it's mandatory to use a US and assess the pericholedocal vessels. And if you see one, probably you can cover such patients with terlipressin as a preemptive measure. So that's the only addition. Otherwise, most of it is, I think, nicely covered. And are we discussing the pancreatitis again?
Yeah.
Okay.
So I will ask a question to Dr. Chatterjee. What is your role? How do you suggest that? How do you in your clinical practice prevent this post ERCP pancreatitis? What are the measures you use?
You have to unmute, Chatterjee.
Can you hear me now?
Yeah.
Yeah, sorry. Thank you for the question. So as Dr. Nalini Guda has nicely elucidated, there are patients whom are considered risk for pancreatitis. For example, if they have had previous pancreatitis, if they are female patients, if you're doing on normal ducts, or you're doing pancreatic endotherapy, these patients are at high risk patients. So most of the patients in our clinic, we are giving intravenous ringer lactate pre-procedure, and we are continuing it 1 to 2 hours post-procedure. We are not, once we are trying to do cannulation, we are trying for cannulation for about 5 minutes if you have got a fellow. After 5 minutes, usually the consultant will take over from the registrar or the DNB, and we do not allow the fellow to keep on trying for more than 10 minutes, because we have seen that if they try for more than 10 minutes and then the consultant takes over, then the risk of pancreatitis is usually more in those patients. And we also don't give high-risk patients to our fellows to start, usually large duct, big stones, normal ampulla, we are giving those patients. Post-procedure, we are giving rectal endomethacin on most of our patients. If the pancreatic duct is cannulated by the guide wire more than 3 times, we are usually putting a single pigtail, single flange pancreatic duct stent. But if it is going once or twice, we are usually not. And we are not usually using dye to find the way, using wire-guided cannulation. So these are the main methods that we are using to prevent post-ERCP pancreatitis.
Very good points, Chatterjee. I think most of the centers, I think, follow your practice. And these are all the standard practices to prevent PEP, that is post-ERCP pancreatitis. Just want to ask any of the panelists, is there any role for ulinastatin?
I don't think so.
No?
We are not trying. It's too costly.
Yeah, it's very costly, and it has not shown any effectiveness even after the high doses.
I think 3-4 years back, I think.
The company people are still promoting it, but it's not useful.
Yeah.
I want to ask Dr. Jha. Dr. Jha.
Yes.
Yeah. What precaution you will take while doing ERCP in a cirrhotic patient? who is having deep jaundice, what are the complications which you can encounter during this, and what are the precautions you will take?
In cirrhotic patient or portal hepatitis without cirrhosis, in such cases, first, if we have imaging diagnosis, then actually we go for the endoscopy and see if any varices, or in imaging there are a lot of collaterals. If collaterals are present or varices are present, in that scenario we take some extra precaution, and precaution in the sense of, actually sometimes I do the US, periampullary US, to see the collaterals around the papilla, because sometimes collaterals just around the papilla and epithelial tissue. So we can take extra precaution in that case, number one. Number two, if there are a lot of collaterals, actually, and patient is in cholangitis, in that scenario, I don't go for sphincterotomy in the first time. Actually, we place the stent and then wait to resolve the cholangitis. And then we try, once PTI and other things actually recovers, then we try in the second attempt for the sphincterotomy in a very careful manner. These two precautions actually we exercise in patient of portal hypertension. And one more thing in these patients, because sometimes even if prothrombin time is normal and platelet count is normal, so bleeding risk is still there. So we always keep this FFP and platelet count and standby. So post procedure, if bleeding happens, and if happens, then we actually exercise the same practices the non-cirrhotic patients for the hemostasis, like APC, like cautery, use of cautery, and other cleave hemocleaves and other things.
I think two more things I would like to suggest in cirrhotic patients, that if they are very deeply jaundiced, anesthesia risk is very high. We have seen, even if after ERCP, patient may not come out. Even if you have reduced the cholangitis and sepsis, patient may not come out of anesthesia if patient is given deep general anesthesia. So I would like to tell people that anesthetists should be aware of the complications post ERCP also. So they should be prepared beforehand to give the minimum anesthesia that the patient should come out of anesthesia. And second thing is, if this patient, cirrhotic patient, they are very fragile. They have tense ascites. So always tape ascites before you want to do ERCP. If you encounter that you have to take a long ERCP time with large stones, so it is always better to tap the ascites beforehand, because they have a respiratory complication after the ERCP. Umesh, what do you say?
Yeah, I think. Yeah, maybe Dr. Jha, you want to add?
No, I agree with these two advice. Actually, we should do the procedure in minimum sedation, so the first recovery.
And Dr. Mukesh is also there. So Mukesh, do you want to add any point to prevent the pancreatitis or bleeding?
Yeah, now I think the topic is comprehensively covered and other panelists has reasonably contributed. Only thing what I wanted to suggest was the frequency with which it is suggested that we should PD stents. We are not doing it, and I've been asking about my Rajasthan group also. We don't do it that often. Yes, we are using NSAIDs for prevention of post-ERCP pancreatitis. So I don't know over the time whether there needs to be a relook on this data.
According to me, I think it definitely helps, because we have seen that when we were not putting ERC pancreatic stent before, like 10 years before, there were severe pancreatitis, because it definitely prevents the severe pancreatitis. Not even if it is not doing the acute pancreatitis, it cannot prevent the acute pancreatitis, but it can definitely prevent the severe pancreatitis.
No, I agree with Sanjay. I think there is no controversy as far as putting up a stent, if there is a pancreatic injection or if there is some problem while doing the biliary cannulation. But only thing, the controversy would be the threshold. Whether you would like to place a stent, pancreatic stent, even if the single wire goes in even once, as Dr. Nalini Guda says. But I usually do not prefer to place a stent if the wire accidentally goes in once, maybe 2 to 3 times or more than that frequently if it goes. Then you
and especially in high risk patient, if it is you are having a high risk, because it doesn't matter if you go for 10 times in chronic pancreatitis.
Yes, correct.
They don't get pancreatitis so often.
Yeah, This is the usual patients, not chronic pancreatitis.
So clinical scenario may be different whenever you want to put it or not.
That's one thing. And second thing, what should be the timing of pancreatic stent removal?
I think it's 2
Within
to 4
5
weeks. I think it is 2 to 4 weeks.
Yeah, I think 4 weeks is
better to remove early. Better because they have seen that chronic pancreatitis and there are chances of stricture developing if you keep it more than 2 weeks. There are chances of developing.
We are removing the pancreatic stents within a week. And we are doing an X-ray to see whether they have fallen out on their own, and if they have not fallen out, we are just removing with a gastroscope.
Yeah, that you can see on your image intensifier also. So
that's right. That's what we are.
No need to do the X-ray because
in the image intensifier. That's what.
But you know, you would have done ERCP. Patient goes for cholecystectomy, and suppose you would have placed a stent, and you would like to remove the CBD biliary stent removal as well. So you could
remove after 4 weeks, both at the same time. You can remove.
You can remove both of them at the same time.
That's right.
Okay.
I have a question. Can I ask this question? Sure. I am a bit reluctant about using heater probe in post ERCP pancreatitis. Thermal therapy is usually not very well recommended. Yeah, I know some of you are saying that you are regularly doing, but what we are doing is we are injecting adrenaline, trying to put clip. If we cannot put clip, we are using a gastroscope with a cap. And if these two don't work, we are straight away going for fully covered SEMS. We are actually avoiding thermal therapy because we have had in the past 1 or 2 episodes, even after aiming at the apex, severe pancreatitis because of using thermal therapy. So I am a bit reluctant to use thermal therapy for post-ERCP sphincterotomy bleed.
Yeah, I think if you are doing thermal therapy, usually you should put a pancreatic stent. That will prevent this. So if you are going to use the thermal therapy, it is better to put a pancreatic stent beforehand.
Actually, when there is a lot of bleed and everything is happening at that time, trying to cannulate the pancreatic duct is not that easy.
No, after control of bleeding.
Yeah.
When you control the bleeding with thermal therapy, you always put a pancreatic stent and it definitely helps.
No, rather than you can use a coag part after using a cut.
Yeah, so we are using that. We are pressing the blue pedal of and not just at the apex. We are aiming at the apex with the board. That is what we are using, but we are not using heater.
I agree with you. Fair enough.
Now you can use co-grasper also. That is also very good. Rather than using the hot biopsy, which is very big, you can use the co-grasper, which is very small.
Yes.
For thermal therapy.
I think.
That's a good suggestion, Sanjay.
Thank you.
Do we have time?
Another
I think we have to conclude.
More than co-grasper is quite a useful accessory. And completion of sphincterotomy also helps in bleed.
Yes.
Yeah.
Sahil, do we have time now?
Yes, sir.
No, sir.
Sir, time kadam.
Okay, so now
Are there any questions?
Thank you all.
Thank you very much.
Thank you very much for joining this excellent talk and then having a great discussion. Thank you.
Okay. Thank you, organizers. Thank you, Sanjay, and all the panelists. Mukesh, Chatterjee, Ja.
Thank you.
Thank you, Jar. See you. Bye.
Bye-bye.